Good afternoon, dear professor and colleagues. Actually, this is topic from the organizing committee. I have to re-explain because I've seen many new audience who are not attending the Professor Joseph lecture today. You know that multiple myeloma is a plasma cell neoplasia that can present in different clinical entity, and they can affect the other many tissue and organs. And you know, recent advances in molecular understanding and management of multiple myeloma have changed the diagnosis and the stratifications of the disease. Now we have a diagnostic criteria that can predict or identify the patients with smoldering multiple myeloma who are at risk of progression to active myeloma. Historically, we treat the myeloma patients after the CRAP, but with this biomarker, we can predict probability from progression from smoldering to active myeloma. The use of this criteria can help us to mitigate an organ damage which can irreversible. The ISS stage or the revised ISS. The revised ISS is use the normal level of LDH and the translocations along with the ISS stage. This revised stage 1 ISS, we can see on my left hand side, the probability of overall survival was not reached in stage 1. But in stage 2 and 3, the probability was about 80 and 40 respectively. Following diagnosis and risk stratifications, we have to choose what is the best treatment options for our patients. Either the patient is transplant eligible or ineligible. Due to limited health resources and financial constraints in most of our patients, we cannot use the risk stratifications properly. Therefore, most of our patients is in induction followed by continuous therapy, especially in my center. But both approach, whether it is transplant or not transplant, the intent of the treatment is the reducing tumor burden. That is the point that we should learn. Now, this is the milestones of myeloma treatment. At the beginning, melphalan and prednisone is a standard of treatment. And then the change of paradigm was in 1999, when several studies showed that the thalidomide-based treatment is superior than any other treatment previously. Now we can have a huge armamentarium myeloma treatment as described by Professor Joseph. Now we move to the newly diagnosed multiple myeloma patients in our center between January and December 2015. There was a total of 42 patients. The ratio, male-female ratio, were similar. This is, I took from the 3 hospital. The Hasan Sadikin Hospital is a governmental hospital, while the 2 other hospital is a private hospital. There are many hospitals in Bandung, but I don't have access to the other hospital. So this is only data from 3 hospitals. The patient's characteristic, male versus female, the age at presentations were older in female patients. And the stage at the presentations are Duli-Salmon stage 3. We are still using the Duli-Salmon staging system because we can apply the revised ISS. When they admitted to the hospital, the presenting symptoms, the most presenting symptoms is anemia, bone pain, and renal insufficiency. One of my patients admitted to the hospital with the lower GI bleeding and due to secondary amyloidosis. And one from my colleagues' patients admitted with the presenting symptoms of pulmonary emboli. As predicted, the diabetes mellitus and cardiac disease was the most common comorbidities, and as well as the immobilizations due to bone pain. Treatment regimen that we used in our center mostly is thalidomide plus dexamethasone. We call it Taldex. And the second one is bortezomib plus Taldex, and then VET. We are not using melphalan prednisone very often. The fatal VTE occurred in 2 patients who treated with thalidomide based, and 3 of 7 VET patients died after 2 cycles, 4 cycles, and 5 cycles, mostly due to pneumonia and sepsis, gram-negative sepsis. And we look to the literature, the incidence of PTE with isolated thalidomide is a little bit low, only 3 to 4%, as similar to the risk of the disease itself. The association of thalidomide with corticosteroid or anthracycline could increase the incidence of VTE to 12 and 34% respectively. The lower incidence of thromboemboli in our patients, even without thromboprophylaxis, is maybe or might be due to difference in pharmacodynamic and individual risk factor. However, a better understanding of adequate thromboprophylaxis according to the presence of the risk factor is an important issue in the treatment of multiple myeloma. Everyone should agree that cancer or thalidomide could increase the incidence of thromboembolic. Although the exact mechanism is unknown, many postulated hypothesis is like this. The study showed that the thalidomide reduced the thrombomodulin during the first month, although they came to increase after several months. Thalidomide increased the PAR1 after exposure to the doxorubicin or other anthracyclines. In one study, patients with multiple myeloma treated with thalidomide, extremely high level of von Willebrand disease. And the other hypothesis is there are SNPs or single nucleotide polymorphism. What about the VET treatment? Tang et al. Showed that treatment-related mortality was significantly higher in patients after the VET when comparing with the MP. And 3 of 7 our patients died in VET regimen. In conclusion, this retrospective data might not be represent the true incidence in Bandung, West Java. However, if we compare to the previous data, there are trends to increase in the incidence or prevalence of multiple myeloma in Bandung. Until July, we have 62 patients newly diagnosed multiple myeloma patients. We are unable to use bortezomib in conjunction with image due to limited health resources and financial constraint. And I see the BPJS was coming also in this meeting. So we hope that the bortezomib could be covered by BPJS. The lower incidence of thromboembolism among thalidomide users, even without antithrombotic prophylaxis, strongly indicated difference in the pharmacoeconomics. And I thank you to my all staff members who gave me data for these presentations.